Thank you for joining us for the Focusing on Family-Based Service panel presentation. We are going to jump right into the presentation. Our first presentation will be from the University of Maryland, Baltimore team. I'm going to turn it over to Kay Connors.
Thank you, Roxana, and thank you to our OVC and JB International supporters for funding this work and also for giving us this wonderful opportunity to present with colleagues. So my name is Kay Connors. I'm a clinical social worker and I direct our early childhood mental health programs here at the university. And when it comes time to introduce my colleagues for their sections, I'll let you know about them. So I've been a social worker for a very long time now. And so as a family therapist, it's really important that this section was put in to this conference. This family-centered approach is kind of instinctive. Families know it, communities know it, but our systems and the way in which we deliver services have a lot of barriers and sometimes a lack of understanding about the value of a family-centered approach to recovery and wellness. And this particular project, we're funded to work with pregnant and parenting women and fathers who are dealing with opioid use while raising their young children. And that can be raising them in the home, or it can be working on various strategies to bring the family back together. So this, we know really that the secret sauce to all recovery, whether it's physical health care, whether it's trauma or mental health treatments or recovery treatments, the secret sauce really is support and relationships. And so families should be at the center of how we deliver services and how we support people on their roads to recovery and wellness. And so beginning during pregnancy and in the earliest phases of parenthood, it is really a remarkable opportunity. And that's what we're going to kind of focus on today. And we've been privileged enough to be funded to share and to test out how to deliver this in our community in Baltimore and surrounding areas of Maryland. So a family support and family-centered approach really provides support and space for parents and also family members to heal. As you know, substance use disorders and addictions impact not just the person coping with that disease, but it impacts the whole family. So everyone needs a chance to heal. Family members really can become part of the treatment plan and be very active at all levels of care, including babies. And my colleague Bree Fellows will talk a little bit about what that looks like. It's a very respectful approach to care, respecting both each individual in the family and how the disease of addiction has impacted them and what they need for their own recovery. And it also respects family choice, family values, family traditions and routines, and the family's unique resilience and ability to pull on their own internal resources for recovery and wellness. But choice needs to be a part of that. Choice is always the counter position to traumas, which are things that are out of people's control. So building on family strengths, and as the presenter this morning or earlier today talked about recovery capital or a hope-centered approach, which I thought was a beautiful way to talk about the work. And for our specific project, we really are always working on prevention and early intervention, either by identifying needs of young children really early, which ultimately helps with all kinds of equity issues by getting kids resources and families resources that they need early in children's lives. So it really makes a big difference in their brain development and overall health. But also we know that addictions tend to have an intergenerational impact. So having a chance to reduce future addiction concerns in the children of the family. So culturally responsive and trauma-informed approaches are part of the big picture of a family-centered approach, as well as including the wisdom and knowledge and experience of people that have lived with the disease of addiction, and making sure that they're central to the support services. We know that there is a ripple effect of this disease of addiction on the families, both past generations and current generations, and future impact on the children. And the things that kind of keep these problems in place, we know from the literature, are related to stigma, both the self-stigma that we hear very painfully expressed by the women in the interventions that we've been able to provide, and the survey that Dr. Dos Reis will share with you. Overall misunderstanding from communities, including provider communities, the division of health and of mental health and addictions really creates divisions where misunderstandings can happen. And then the overall kind of fear and misunderstanding from the community at large. And that gets in the way of really creating a pathway to evidence-based treatments, including medication-assisted treatments that are really vital to saving the lives of women and parents with opioid use disorders. Unfortunately, there is a shortage of family-centered treatments, and we've heard from the moms that we've had the privilege to work with how much they desire to have programs include their whole families, their partners, their children of all ages, and also kind of the unique opportunity that those early parenting years have in motivating women and supporting them in their hope for recovery. So these silos lead to fund, gaps in funding opportunity, problems with billing. For example, these wonderful programs that Bree will talk about later. We in our state have a hard time billing Medicaid for parent programs, but they really should be part of the package of care for parents in recovery. And these are from a two-generational perspective. If we don't have the whole family, if we don't have this family-centered or whole family approach, we really miss opportunities to identify the needs of children. For the little kids that we focus on, the need for developmental services, including social emotional supports and mental health services, and for older kids, using those opportunities to help them reduce the risk of future early onset of use and hopefully prevent substance use problems. So we are very grateful for, we're part of the 2018 cohort. We call our project the Baltimore Network of Early Services and Treatment. So the BNEST is our kind of our acronym. And so our goal really is to build kind of a supportive nest around the family, that the families that are dealing with opioid use. So to provide training to our colleagues and child serving professionals so that they can better understand the needs of families dealing with substance use and opioid use issues, and how it both is related to trauma in the past traumas and current traumas that might be occurring for the family, so that they are more receptive to identifying kids and families with these needs, and also supporting them in a hope-centered and trauma-informed way. provide evidence-based and trauma-informed services to children 0 to 5 and their families. In our clinic, we provide an array of evidence-based practices, but also we've been invited in as partners to recovery programs, outpatient and residential, to bring some of these services to the families there. And then create other aspects of our grant has been to create a resource map to think about the needs of families with young children, and also to create the community needs assessment, family needs assessment that Dr. Dos Reyes will talk about, so that we can really include family voice in the project. And ultimately, our next step is to create, to think about how to sustain and spread some of these practices through a breakthrough series collaborative, which is a kind of an innovative training and implementation strategy. So the lessons we've learned so far is very aligned with the literature, which is the need to address stigma in a multifaceted way, and to create access to evidence-based treatments, both that are treatments for addiction and opioid use themselves, but also evidence-based treatments that are known to support families and family recovery. Need for trauma-informed responses. The mothers both have a high level of childhood adversities or ACEs, and adult, traumas that they experience as adults that are all very linked to their addictions and substance use disorders. And then a need for family-centered supports, including programs that improve parenting skills. As parents feel more competent as parents, and their sense of being able to keep their kids safe and help their kids grow, that it mirrors back and shines a light back on them and supports their own recovery as well. So it's a two-generational approach. Both get benefits from those kinds of interventions. And ultimately, advancing the cross-sector collaboration is really important. And we've been starting to make some really good relationships with recovery programs, but also with the departments of social services. Providers from the mental health and recovery world are concerned about the family's interface with the Department of Social Services, and the Department of Social Services is really concerned about being able to get the resources to those families. So starting to break down some of those silos is a wonderful opportunity. So in summary, just thinking about the considerations for mothers in recovery, that trauma affects how people and families approach services, even though they might be designed for them. We have to put a lot of work and effort and engagement and partnership to help people get involved in those services. And that ultimately families and relationships are the main ingredient to recovery and healing. Those protective factors facilitate healing, both for the children and the parents as well. So a family can be an important protective factor in the recovery process. And women in recovery for substance use disorders greatly care about their children and their families, and have a very strong desire to be good mothers. And pregnancy can serve as a very powerful motivator to start opioid use and substance use treatments. But many women say that things fall off after the baby is born. So we know, if any of you are a parent, that those first 3 months and those first 3 years, you really can't do it alone, and you really need a lot of support. So it's a really powerful time to think about supporting recovery and family resilience. I'm going to pass it off to my colleague, Dr. Susan Dos Reyes, who's a professor in our School of Pharmacy here at the University of Baltimore. And she's been the research lead for our needs assessment survey.
Thank you, Kay, and thank you for that nice opening information, because I think once we go over the what we're learning from the needs assessment survey, I think it will really bring home some of the comments that you just shared, importantly so. And a lot of the work that I do really does focus on the families, and families' involvement in making decisions about treatment are so very important. So what we have today is basically a little bit of what we've learned from our survey, and the needs assessment survey is quite extensive. We have 13 different sections, and so we do collect comprehensive information from these moms who have children under the age of 5 and are in recovery. Our goal is to complete 60 surveys. I shouldn't say we, but Kay and Bree and the team have really done a fantastic job and have completed 46 of the surveys with these moms, and we're on the tail end of that recruitment now. So we're showing you today some preliminary information. Given kind of where we are in the pandemic, most of these surveys have been done virtually, but in some cases they have been done in person. So far in our sample of women who have participated, the average age is in the early 30s, and you can see that the majority of these women are between the ages of 20 and 40 years. 3/4 of our sample is white, and about 1/3 of them have less than a high school education, and a very small percentage of them are actually employed full-time. What I'm going to share in the next couple of slides is a little information about what we've been hearing from these women, and that speak to the level of trauma and the need for services that these women are looking for. And this slide here is a summary of the measure that collects information from women on the ACEs. And you can see that 40%, or almost half, have a high level of trauma, and the average number of ACEs is a little over 8. So truly women that have are living with a tremendous amount of trauma. And so I'll switch to the next slide. We had a few open-ended questions on the survey, and I think it's often very compelling when you're able to look at what individuals tell you in the context of these surveys and things that come from their own words. And so in this question here, women were asked, if you pick 2 areas that would improve your life, what would they be? And there were a number of different responses from women. I tried to kind of group them into 2 overarching concepts or categories. One that fell into basic needs, and one that fell into childcare and resources for their children, which speaks exactly to what Kay just shared in terms of the needs for these women. And when we look at what they're reporting for their basic needs, you can see that by and large, it's around safe housing and affordable housing, a place where they can kind of feel safe in their neighborhood. Some, I think, very basic but very important fundamental needs for all of us. And in terms of the children and the resources for their children, again, looking for childcare and educational support for the children so that they can thrive as well. And being able to have childcare and accessible therapy for the whole family is another comment that came through in terms of this particular question. So given that they reported kind of what the 2 areas they would like to have that would improve their life, the follow-up question to that was, if you were in charge of creating a program to help parents in any stage of recovery from substance use disorders with areas you just mentioned, what would it look like? And so on this slide here, I pulled out a lot of the comments that were related to the family-oriented perspective. And what you see, is like allowing programs that allow the parents to bring their children with them. and also not to be exclusive of dads. So have the dads be part of that. So kind of speaking to really the whole family perspective and having the whole family part of that program. I think the other thing that kind of stuck out when I looking at the comments and the feedback is I would have parents come with their children to do hands-on activities, and the examples that are given, like a grocery shopping list and family therapy activities, is really quite telling in terms of when you think about putting a grocery shopping list together. You really think about some of the real kind of basic needs and what are some of the, you can kind of think of, access to healthy food and what would go on that list. And I think that's really quite telling when that's an example that they would like to have as a hands-on activity with their children, because there's some learning behind there. A place where children can live with you. And so the separation of moms and their kids clearly is something that is missing and they would like to see in programs. And then lastly, I would want the children to be part of the group so that we could rewire our brains to learn to be sober parents. And I think speaking to the comment, Kay, that you just made about something about pregnancy being a parent and really being a sobering effect, and that this is clearly something that that these moms were looking for, and I found really quite moving. And when you see it on paper like this. The next area, and this is the last little bit that I'll share with you, was around resource assistance for families. And when we think about kind of what are some of the things that families are looking for, and we think about, it also relates really to the child care and education, but, to help better myself and get on my feet, and for the program to include my children and help so they will have a good education. So thinking forward ahead to how their help can also be transcended down to help their children thrive. And a child care program for all kids in the family. And so when you think about all the siblings and how all the siblings are impacted by this, again, a healthy food program and programming for trauma and parenting when in recovery. So again, speaking to the needs of these moms and the impact of trauma and their efforts to really kind of move beyond and get to a better place. So I'm going to hand the next piece over of our talk to Bree, but wanted to give you a little bit of a understanding of some of the things that we're hearing from women in the field. So thank you for your attention. I'll pass it over to you, Bree.
Thank you, Susan. Thank you, Susan and Kay, for kind of setting us up. So I'm going to talk a little bit about our interventions that we found most helpful in the programs that we got to work with. And again, I'm Bree Fellows. I'm a clinical social worker and work closely with Kay and Susan, particularly on this project. So we've had the great privilege in a large university and urban town to be trained in multiple different parenting groups. And but what we learned from the research is that women who have had histories with substance use, in particular opioids, there's part of the brain that gets hijacked, that typical parenting programs that focus solely on reading cues and sort of rewards and consequences just aren't available to these women. And they become more irritable, and it affects the parent-child relationship in ways that just aren't a good match for where they are in their recovery process. So we had the great fortune to be trained in other models that we'll talk about a little bit more. But we do know, despite that really to improve outcomes for young children and improve relationships, they need someone in their life that has it, that they can build a strong attachment with. Because the absence of this can have the greatest consequences on these children. So thinking about, what that opioids does to the brain, but then we're also helping to think about how can they build a strong attachment, is where we thought about which programs fit the best for this population. And so we had a good relationship with some programs in the community that were willing to take us on, and our training had been with a Zero to Thrive program from out of the University of Michigan. And their program focuses particularly on these 5 components. So they include an attachment-based parenting psychoeducation. So it's really focusing on, building a relationship with your baby and young child, but also your other supporters in your world. Also supporting that parent-child interaction, enhancing social supports, connecting to culturally relevant resources, and a large component on self-care. So all of these things are involved in this particular curriculum that we use. Now, Strong Roots is kind of their overarching program that encompasses many of their groups that they have designed. Our particular use of their model was a mom power model, and it focuses on this tree that embodies these things that you can see on this slide. So there's strong roots that include nurturance and repairing relationships and restoring. We're not always going to get it right as parents, and how do we repair and nurture that relationship with even the youngest child, but then also helping them to explore and attend and find joy in what their children are doing, while maintaining a secure base within themselves and taking good care of themselves and being a safe haven for their children. So we have been able to do this, thankfully, in person in programs where mothers are and get to be with their children. Generally, programs can only have one of their children with them, which is their youngest child with them, but the women hold in mind their other children that can't be with them. And we talk a lot about how they can incorporate them when they're able to go out on visits, and certainly maybe if the grandparents are involved or the fathers, and how they become supporters for them, to focus on their recovery and parenting their young child. So we've had, I'm not sure if this slide's been up to date, but we've had 24 mothers did attend a workshop, and currently 76 mothers, including their babies in treatment, have received this mom power intervention in and around Baltimore City right now. So we've gotten some really good information and anecdotally hearing from the moms in the programs that this seems to be a really good fit for the moms based on the components that it involves. So just a little bit more about exactly what Mom Power is. It is a 10-session parenting and self-care skills group program for high-risk mothers and their young children. So it's 10 weekly groups. You could probably do it more often. It is 10 sessions. It could be 10 weeks. It could be more. And then there's individual sessions where you check in on the moms to see how things are going about midway through. And it's showing a lot of promise to that, because it focuses both on the maternal mental health, in not necessarily diagnosing them or doing a full assessment of them, but recognizing that they're struggling either with substance use or depression, things like that, and helping them to build their own resources and coping skills, while also focusing on the parenting competence. And it says clearly, we do not give advice in this program. We're really helping you to understand your child and your relationship, and sort of some child development and what you need most in your recovery and parenting goals as you go forward. So these are the 3 interventions that we focus most highly on. The Mom Power intervention, you can see there's more information on the Zero to Thrive. There were a subset of parents too that out of Mom Power or out of program interest wanted more intensive family therapy. So some of us that have been trained in child parent psychotherapy have been assigned those cases and work with them. Most of them prefer to have the treatment in the program. So we'll go and do this child parent psychotherapy work in the programs around their schedules that works for them. We were opportunistic in that we were allowed to go into these programs. We could have done it virtually, but we really felt strongly that this works best inside, in person. And the one component I didn't mention about that the moms like the most in the Mom Power groups is the parent-child dyad activity that comes at the end of the group. So the moms have a group for about 30 minutes, and then the last 15 minutes is they go and get their babies and young children and get to interact together and read a story and sing songs and have a good time together. So I think I've done it. It's 3:05, so this is us. For more information, don't hesitate to reach out, and we'll be around afterwards for a few questions.
Thank you, Bree. Thank you, Rosanna.
Yeah, thank you so much for the presentation, University of Maryland, Baltimore team. Now I'm going to turn it over to Nez Perce, to Rebecca to present.
Can you hear me?
Yeah, now we can hear you.
Oh my gosh, thank you, technology, for being so wonderful. Okay, so Tatsumeiwe and greetings to you all. Ina Monique Was, Himatu Teleketset, Ego Sayapatimki, Rebecca Lehman. It's an honor to be here with you today to share this space virtually. A big thank you to JBS International and obviously the OVC for these opportunities to share our stories and our journeys about what we're working across the nation. With that, I'd like to take a moment just to recognize the Indigenous lands that we're all on, that we're all sitting upon right now. I think it's important to acknowledge those people and those that went before us and took care of this land so that we can still be here. You know, we're connected, and I'm grateful for that. So as I said, it's an honor to be here today and to share the journey the Nez Perce Tribe has taken to develop and implement Inhanyuma, my relative's home. This is not, my next slide is not going. Okay, there we go. So I shared with you my Totokan name, Hinmatu Teleketset, which means thunder roaring from within. That's my Indian name. It was given to me by one of the oldest females of our family, right before she passed on to the spirit world. My English name is Rebecca Lehman. I'm an enrolled member of the Nez Perce Tribe and a licensed master of social work in the state of Idaho. I've been with the child welfare team for the tribe for a little over 5 years. And, you know, the Nez Perce Tribe is a sovereign nation. We have our own government, we have our own entities, and the child welfare program is a branch of that government. An interesting fact, I guess, about our reservation is it's about the size of Rhode Island, and it's located in north central Idaho. We serve all tribal nations under or within the boundaries of our reservation, which means that we don't exclude. We try to serve all of our tribal people. The child welfare team is extremely diverse. I've listed the programs that I oversee: the child protection team, the children's home, which is a group foster home that kids can stay in while they're waiting for family placement or kinship placement or even reunification. Inhanyuma, which is a sober living home that I'll be talking about today, and the Init home. It's a teen shelter that will be opening soon through another OVC opportunity that we identified a need for a big sister or big brother of the children's home for those teenagers that didn't quite fit in the mold of the children's home. While I've been here, I've been able to serve various different capacities in child welfare, from caseworker to foster home licensor, education trainer, teaching parenting classes, direct interaction with kids, child abuse investigator. I'm a forensic interviewer. So now I'm the director. But I think it's important to know this team, we are small, but we are mighty. We have all different skill sets that we all bring to the team to provide services. Excuse me, I am not feeling the best, so please forgive me as I get through this. Next slide. Can't get it. Okay, so how did this all start? First of all, we identified a need. Of course, with all child welfare programs, our focus was and is family preservation and reunification, especially reunification if a child was deemed unsafe and a removal was warranted. So secondary to that, we have a long-standing goal to reduce the time that kids are in foster care. We noticed in 2017, that our battle with the mind changers or addiction, substance use disorder was really increasing. Our caseload was increasing, all specific to drug endangered children. Our area was just getting overwhelmed with the effects of the opioid epidemic. So a battle of the mind changers, if you will. This is an idea that comes from our cultural teachings that is throughout much of the White Bison curriculum that we utilize heavily in this program. So success with that battle came when we were able to get mothers into treatment. We were able to luckily find programs or treatment centers that would allow their children to join them while they were doing their programming, while others couldn't. Their children remained in care. So we were looking at reentry. What does it look like when these moms come home from inpatient, from incarceration, or what if they didn't qualify for inpatient and they still had to stay home or got to stay home to do their best to do that healing work that they needed. So with that, we identified that housing was the biggest barrier that we had across the board. It was hard to find housing that was safe and that was sober. We just simply didn't have that. Some people did suppose, but not all. And this led to some opting not to return home. If we found a treatment facility in Oregon or in Washington, wherever the case may be, it was almost safer for them to stay in the area, and we would then have to relocate the kids to successfully reunify, which isn't necessarily bad, but it took them away from home, took them away from their connection to their culture and their community. So what we really looked at doing was building a healing forest. The healing forest is also part of this Fulbrighty and White Bison curriculum that we really heavily utilize. And the best way to explain that, I guess, is when we think of having a little plant, we have it in the greenhouse and we're feeding it and we're watering it and we're giving it plenty of sunshine and praise and all of that. Well, there comes a point in time where we have to take that little baby plant and we have to put it in the environment, put it in the garden or whatnot. And sometimes, unfortunately, the plant didn't always thrive, which was similar to what we were seeing with some of our moms, some of our parents that were returning. They came back, they were on fire for recovery, but due to the circumstances, fell short. So, next slide. No. There we go. So we were awarded this grant, this OVC grant, Enhancing Community Response to the Opioid Crisis, Serving Our Youngest Victims of Crime. This was direct services grant. Of course, there was a lot of work that had to be done before this home was actually placed and opened, but this is what the grant covered, was actually the home, the construction and the infrastructure, the home furnishings, service to participants, and I'll cover that a little bit later. But this is what we worked for. This is what we spent hours working on. Next slide. Okay, so I'm really sorry about that. I'm pushing buttons, but it's not really working. So this is the exterior of our house. This is the back door, or no, this is the picture on the left is I believe it is the back door on the south side of the home. We have 3 entrances to this home. The picture without the decking put on, those are the front entrances. That it's just a beautiful house. It's a manufactured home. It was actually part of this was a barrier, was getting the home actually placed because of COVID restrictions and whatnot. Next slide. And this is the interior of the house. The first picture there on the left, that is a picture of our dining room. And this is where families can They can share meals together. They can share this space to hold meetings, the house meetings. They can have classes. They can do arts and crafts with their kids. We can enter the home. Staff can enter the home and deliver curriculum. The center picture there, that's the living area. There have been some updates since this picture was taken. There's now a television there and some other home furnishings, but this is one of the first shots that we got when the home was open. This last picture here on this slide is the kitchen area. It's a good sized kitchen with a very large pantry there in the back. It is a nice sized pantry that many might be jealous of. So that families can separate their belongings, our favorite snacks or if we have food allergies or whatnot, but they're able to just spread it out. There's 3 ovens, there's a stovetop, there's a dishwasher, refrigerator. This is just a beautiful, beautiful home. In all of these pictures, you might be able to see some of the entrances into the bedrooms. This is a 4-bedroom house, 4 bedrooms, 2 bath. At full capacity, theoretically, if we put families together, a mom and a baby together, a mom and a younger child together, we could house up to 18 individuals, mothers and children, for this safety net. Next slide. Thank you. So Inhiniuma, what does that mean? Inhiniuma, actually, it means my relatives in Nez Perce. This is a Nez Perce word that translates. It was given to reflect the Nez Perce views on families. We're all related. We're all relatives in some way or another. And we wanted to not only utilize a Nez Perce word, but also choose a word that expressed our outlook on the meaning of this home. All of our relatives are welcome. Excuse me. Admission to the home is focused completely on the child's eligibility for enrollment in any federally recognized tribe. This home is focused on services to the child to benefit the family. So the mom does not have to be enrolled. They can be completely non-tribal, and they still have access to this program and this support. Of course, with policy and procedure, along with the house rules, those are more focused on the mom. Those rules consist of like curfew regulations, visitors, check-ins, and other things to assist in the accountability in the recovery process. A lot of these policies and rules were an adaptation from the Oxford House model, that well-known model of sober living that many of us are probably very familiar with. We felt like this model helped us with the foundation and the framework of the house for accountability and self-governance. This house isn't staffed 24 hours a day, 7 days a week. So we do ask our moms that do enter the home to govern themselves and hold each other accountable. This would include the missed curfews and the not coming home or having visitors past visiting hours or drug screenings or failed UAs. We really use the model for that accountability piece. House meetings are held with staff present to support, and we assist with any conflict resolution. Another part of the Oxford model that we really appreciated was the financial growth capability. So this would come more into play, I think, when the grant closes and we focus on self-sustaining measures to keep it going. But through this, they learn the budgeting, how to pay rent, what does it look like to be out on my own when we move out of Inhiniuma. Next slide. Direct services through this program it's pretty vast and far-reaching. We'll get more into the case section in the case plan in just a minute, but this home is utilized for child-parent visitations, especially when first coming home from inpatient or from incarceration. Some moms aren't really, ready to have their kids full-time, and we respect that, we honor that. So this space gives us opportunity for supervised visitation and that slow transition into parental care or even a change in custody. Our direct services also include transportation for the children or the mom to any medical, dental, optical, therapeutic appointments, even trips to the grocery store if that's what's needed. We are in very rural Idaho where we don't have, we have public transportation, but it isn't like we can just run to the store real quick. So we recognize that, and staff is definitely available to do that. And of course, we assist with clothing and hygiene products as needed, especially when moms and kids come home or enter into the home. And then crisis management, whether that be related to mental health issues or substance abuse or relapse. Staff may not be there on site 24 hours a day, but we are available all the time. You know, our phones are always, our phone number is always available. We're always available to our clients. Even if it's beyond our ability to address, we'll still be present and help get them to the next step. So this all comes together in the case plan with the help of 2 staff from the ICW team. A requirement to be an in-home UMA is to have a case plan, whether that be through an in-home service plan, which is a child welfare case that is not under court supervision. We kind of do it on our own. But then, of course, also those cases that do require court intervention. The assigned caseworker, we really do active efforts. You know, we have reasonable efforts, and then we have active efforts. Nez Perce Tribe operates at active efforts at all times. We're in their business. we're always available. So we developed the case plan through the use of a visual mapping tool. This tool covers the biopsychosocial, spiritual needs of the person, and it's all written in first person. It's a really handy interview tool as well to help build rapport. From this, the case plan is constructed, and we found that building our case plans in this way really helps our families, our children and our mothers be successful because they're setting their own goals. Of course, part of our case plan requirements would be to mitigate safety factors, right? So we really join them in how do I meet your need and how do you meet our need and how do we be successful together? The action plan. The action plan is specific to the in-home UMA coordinator. This is constructed with the coordinator and is more specific to the recovery goals and support. The wraparound services for the mom, and how to meet the needs of their case plan, maintain sobriety, and also access all local, tribal, and state assistance. Excuse me, next slide. Okay, so through the case plan and the action plan, of course, we identify the basic needs of the child and the family. But the thing I want to pay most, specific attention to is that last part that we use on the visual mapping tool. I think it's one of the most important parts. This is the cultural and spiritual needs of our family, of our children and our mothers. This is where we identify what they feel they are missing in their cultural and spiritual health, and we help fill that need. The Nimipu Variety movement has been one of the most powerful, successful grassroots movements on the reservation. We were fortunate to work with a fire starter who actually came home from treatment and was like, I want to be a part of this and I want to help get this off the ground. So she really helped partner with our program to get this going and meet the needs as she saw it. So with this fire starter, Nimipu Variety took off in our 2 most highly populated areas on the reservation, Kamiai and Lapwai. This group, along with our program, has provided cultural activities like the ones that you see there, the drum making, the net making. These activities, they brought families together. We were able to identify community members who had knowledge about the best places to gather, to dig roots, or to camp out. So in turn, we empowered them to teach. This opened up the opportunity for that connection, even with family members who had lost that connection due to addiction, due to those mind changers, that community, that family relationship was lost. The cultural specific curriculum that we have in our case plans is through the White Bison Native Wellness Institute, and of course the National Indian Child Welfare Association. All of these listed curriculums have a parenting aspect to it, or wellness in our emotional and spiritual selves. So they not only covered parenting, but they also covered grief. They also covered communication, cultural connection, belonging, understanding who we are as Native people. And the beautiful part about these curriculums from White Bison especially is that we can tailor fit it to meet our needs in our culture, in our community, and where we're at, and still maintain the integrity of the curriculum. So there's little bits in there where we can add our own Nez Perce stories. We can add our own cultural beliefs that may not be seen on the different parts of the different parts of the country. Next slide, please. Oh, that one. All of our direct services, without a doubt, work simultaneously with our community partners and stakeholders for wraparound services. Mimipu Behavioral Health, Change Point, Riverside Recovery. Those are three of the more prominent outpatient service providers in the area. Mimipu, a variety of members, recovery coaches from Mimipu Health and the Warrior Down Group, which are the Warrior Down Group is people in recovery who went through special training at White Bison to be peer support. They're like recovery coaches, but they're known as Warrior Down Group. These grassroots organizations, they work with the official service providers to meet the out of the office support. I don't know if that makes sense, but they're like the little safety net that falls behind our participants to really put their tools to use when they're out in the community. Mimipu Health is also a main provider for any services that might be needed for our children. Of course, the children are always welcomed and encouraged to actually participate in any of the variety activities. But for mental health services, Mimipu Health is highly utilized. Secondary to Mimipu Health is we have a children's mental health provider that's located about 11 miles away in Lewiston, Idaho, that provides equine therapy. Working with the equine program has been just absolutely amazing. It's really something to see children just change right before your very eyes when they interact with those horses. It's like the barn turns into this safe place where they can be their genuine self and interact with their horses in a safe way and mitigate that anxiety and really open up to their providers. Our other community partnerships consist obviously of the ICW, the Indian Child Welfare Team, Nez Perce Tribe Law Enforcement, Idaho Department of Children and Family Services. What we really appreciate from the state of Idaho is their access to services, especially with the infant toddler program. This is a program that provides occupational, speech, physical therapy to children who are born drug affected or came into our care and it was identified as a need that they're a little bit developmentally delayed. So they help provide services to those children. The Uyik Kimti program is our domestic violence program here on the reservation. And so they do work with some of our cases as well. Lapwai School District and Nimipu Community Health. Nimipu Community Health is where we utilize those services like car seats, WIC, really anything community health. Next slide. Thank you. So from all of this, what are we learning? We are definitely learning to be flexible and creative. All of the learning curves and barriers put forth by the COVID pandemic were tough. We had never done anything like this before. None of us in the social services department had built a house. We had never thought of what it takes to get bids for construction. Didn't consider sewer lines or water lines or septic tanks or anything like that. We were just learning so much. And all of these teachable moments were very humbling. Like, oh, guess we should have thought about that. Or, oh, now we know for next time. And we started this off as a team project. We get to figure it out. We are experts on ourselves. We are experts on our communities, and we get to be the ones to lay this path for those that are coming behind us. We would sit down as a staff and review all of the policy together, line by line, sentence by sentence, and we would hash it out. Sometimes clarifications were needed, and sometimes those clarifications led into new policy and new questions, and it was definitely learning. There were times that we definitely got frustrated. There were times that we got challenged, but we definitely came away with just an amazing learning experience. And even then, after we thought that we were all done and we were ready to submit it to NEPDIC, which is our governing body of the government of the Nez Perce Tribe, it was still, well, we have questions, which turned into another working group to answer those questions and fill in those gaps. Along with that, obviously, we didn't know what we didn't know about co-occurring disorders. We didn't know what we didn't know. So we got to learn more about mental health. We got to learn more about how trauma impacts those disorders and how the anxiety and the depression, and even when we would slip into a psychosis, how we could meet those needs to benefit our kids. We didn't, building this program, it was really focused on the opioids, right? It was serving our youngest victims of crime, and didn't necessarily take into consideration that co-occurring piece, the what if. Well, we're learning it now, and we're grateful for that learning experience. We continue to learn the importance and impact of connection and culture as we continue our battle with the mind changer. We learn that truly the opposite of addiction is connection, and those connections that we build or make strengthen our relationship and our healing for us, so that our reservation can go forward in a good way. Next slide. So our journey continues. We're always learning more, as I said, about how we can be better, get better, and do better. Some of the most significant pieces of policy that we're wanting to review include the ages of the children. Right now, our cutoff age is 12, and we're learning that some of those insurance questions and liability questions we can modify, because we've had mothers and children that had teenagers that were 16, 17, 18 years old. So even though we have this safe place for the mom and the children, if the older kids were over the age of 12, they couldn't necessarily live. They could just come and visit and spend time. But we were kind of missing that piece of fully integrating the family together. We also want to increase, I missed one, child custody. So we want to take a harder look at child custody, specifically when a mom has given guardianship of their child away while they navigated treatment, while they, whatever the circumstances may be. What does it look like for that guardianship to be returned to the mom? Sometimes guardianships can be held up when family wants to see, I want to see you be sober for this amount of time. While I'm in the sober living house, I can do it in here, and it's still like that I want to see proof piece. So we want to figure that out to help assist in that successful reunification, even if a guardianship has been long withstanding. We want to increase our awareness of the program. Much of the reservation, they know that we're here, but not necessarily all of the services that we provide. So having this program under the umbrella of child welfare, there's that stigma of child welfare, right? Of child protection, where I don't want to get involved with child protection. I don't want to mess with that. So we really want to break down those barriers of stigma and get awareness out there that we're wanting to get ahead of the problem. We want to focus on prevention. We want to focus on family preservation and getting ahead of this to help our people heal and go forward in a good way. So I think that's what I have for you today. Last slide. So Himakas Katsiyaya Oikalo, there is my contact information, and I also listed the contact information for Jasmine Haigal. She is actually the Inhumuma coordinator. She's the main point of contact for this program. Thank you.
Thank you, Rebecca. Now we're going to open it up for questions and comments via the Q&A. We did get a couple questions for both presenters. I did see the University of Maryland, Baltimore did respond to a couple, but I do want to read them in case any participants have missed it via the Q&A, but you should be able to see the response. The first question was for the University of Maryland. Such a wonderful project. Thank you for your work. I find myself wondering often about our system's lack of capacity to include all members, specifically children and programs. Do you have thoughts or recommendations that you feel or should or consider to be considered to support more inclusive family support, engagement, and treatment, both in outpatient and inpatient? If you have thoughts specific to one or both, thank you. Ms. Connors, did you want to just share your response, or I'm happy to read it as well?
Oh, sure. I'm happy to. I do know like there are policy barriers and billing barriers. So we are trying to work with our state Medicaid. So if you can develop a good partnership, we have a infant and early childhood policy financing group where we get to talk with them specifically so they start to learn about some of the challenges, because billing is usually just for a person, an individual. So the idea of billing for a family is a very tough one. So that's a hard one to overcome. So we've mostly counted on grants and contracts to go into programs that are doing the main work of recovery or addiction. We also do it in school and primary care. So we bring ourselves out of the clinic into the programs. And that's been our main strategy kind of across different systems, primary care, addictions, early education. They have given us in the recovery programs and our outpatient program, they've given us kind of the parent group time to run the group. Many programs do have like a parent hour or parent class. And what the moms have told us is that they've been to a lot of parenting classes that give information around child development and safety, but this is one of the first one that focused on them and their self-care, as well as the relationship aspect, making a relationship with your baby. So learning to understand their building roots moments and their branching out moments, and to respond in kind. The other thing we do is practical stuff like bring baby books and diapers. We partner with a local diaper bank. So that's always a good engagement tool and helps to, create a good partnership. The other question was about the training. So the developers of Mom Power are Maria Muzak and Kate Rosenblum from the University of Michigan Zero to Thrive program. And we highly recommend working with them. They've been terrific partners.
Thank you. The next question that came in was for Rebecca. Can you elaborate a bit on the curriculum that you referred to?
So we use various different curriculum, and I think so. What I'll say is through Native Wellness Institute, we utilize healthy relationships, Native American wellness, and healthy relationships. This focuses on how to communicate, how to have healthy sexual relationships, how to have a healthy conflict resolution. There's 7 weeks of curriculum through that. Through White Bison, we utilize understanding the purpose of life, which is a curriculum more focused towards kids and understanding our connection to our culture and our community. Mending Broken Hearts is grief. Daughters of tradition, sons of tradition, mothers and fathers of tradition. Those are more focused, obviously, on the boys and the girls and the moms and the dads. And how we connect to each other in our healing forest to be well. And then finally, through White Bison, we have Celebrating Families, which is like family group, like learning how we connect to each other how parents and children interact in a good way, and how we find healing through our past traumas, and including generational trauma. As Indian people, generational trauma is it's a very large part of our present day life. It isn't so long ago. It's just part. It's embedded in our DNA. So, but we use white bison the most, followed by the Native Wellness Institute, Healthy Relationships, and then Positive Indian Parenting is through the National Indian Child Welfare Association.
Great, thank you. The next one also came in around direct services of what arts and crafts are being used.
Arts and crafts, we do a lot of traditional, a lot of cultural arts and crafts, beading of earrings, beading of necklaces, beading of medallions. We have made dream catchers, traditional dream catchers. We have done ribbon skirts and ribbon shirts. We've done wing dresses, which is all part of our traditional regalia and attire for entering ceremony. We've done hand drums. I think I listed that, and fishnets. So Nez Perce, we have dip nets that we have worked with our youth to teach them how to do that.
And then you did get another one. It says, Rebecca, I love your program, such a needed resource and keeps families together, growing and healing. Do you plan to develop more homes and other funding strategies utilized to establish these facilities?
Yes. So that last listed program on that one of those beginning slides, the Innate Home, that is a children's home for teens. So I mentioned briefly that the children's home is a brief foster care placement while we seek further placement. So we identify that the teens and the littler kids, especially if a teen escalates, it can trigger our younger kids and scare them if they're having a bad day. So the Innate Home, it was just constructed. We're waiting on those water lines and sewer lines and that to be set up. But Jasmine and I were actually just last week, we're talking about what's it going to look like to also get a men's home. So to get a men's home for fathers and babies to also have a safe place to go when, sometimes I think we focus a lot of our energy and a lot of our services into the moms. And sometimes, dads are the ones that are going to come forward and do the work if they're at that place of surrender and that place to get the healing that they deserve. If we can work a case with a dad, we need to work a case with the dad. So we're looking into that.
And then I think the next question that came in also ties in a little bit to that, like what are some of the issues with the building, if any?
The issues with the building. The sewer line. The sewer line. It's funny because it's not. But constructing a new home, you don't know what you don't know. So when we're connecting sewer lines and water lines, it was like, ooh, well, that didn't work very well. But structurally, the home it's great. But I think those are the things. That's the thing that sticks out the most in my what's wrong with the building is those functional construction pieces.
And then another one was the lessons learned, and especially the co-occurring piece and your team's pursuit of learning is phenomenal. Congratulations on your work. So it's more like, a comment.
Thank you.
And then one other question that came in is aftercare sponsorship and meeting attendance a part of a mom's recovery plan? Do the moms have spiritual support via tribal spiritual cultural leaders?
Yes. So that is all identified in the action plan with Jasmine, with the Indian Yuma coordinator, is identifying that piece of what do you want to learn. You're in charge, and we're just here to point you in the right direction. So if they want to get more engaged in Willisset, which is or any of our religious cultural teachings, Longhouse, Willisset, they want to learn how to sweat, they want to learn how to sing, though we support that. And if we don't know, we seek it out. So is there a spiritual guider or a spiritual, like a medicine man assigned? No. Because I feel like, culturally, I'm going to say I can't assign you a medicine man or a spiritual leader. That connection to your leader, that connection to your mentor is a very personal and intimate thing. So we can point in that direction. And if that connection is made, we can cultivate it and support it. I don't know if that made any sense.
Okay. And then I'm not sure, I think I might have skipped this question. Can anyone refer clients to you?
Me?
It came in, I think during your presentation, Rebecca, but it's open to also the University of Maryland, Baltimore.
So for myself, yes. So a referral can come. You can reach out on those emails to either myself or to Jasmine, and we can send an electronic copy of our application and see if that applies. If you're working with someone in our area that you think that this program can be a benefit to, then by all means, we'll accept referrals from anywhere.
Yeah, we're working in the Baltimore and Baltimore surrounding area. So if you're in that area, give Bree a call.
So at this time, I'm not seeing any additional questions and comments. This has been great. Do you guys have any additional comments that you'd like to share? Anything with the attendees?
There was one additional one about fathers. So I, under this grant, we unfortunately didn't include like a special attention to fathers, but we've learned during the surveys and by listening to the women. So we have a kind of a companion or similar grant through the state opioid response to provide parent programs. And we made sure that we put a fatherhood initiative into that. So starting with training providers to better develop the skills to include and engage fathers. And then we're going to create with a fatherhood expert, Patrick Patterson from Global Partners for Fathers and Families, a father-child intervention and pilot it. So we're making progress.
I just wanted to take a moment again to show gratitude to OVC and JBS International and to all the attendees out there and presenters who are working, who are putting in your best efforts to be of service to your communities and to our children. Our traditional teachings include that our kids are our most valuable assets and that we always go forward in thinking of the next generation to come behind us. So I'm just grateful for all of you and the opportunity to share this space. And thank you all for the work that you do. You are noticed, you are appreciated, and thank you.
Thank you to both of you for such a great presentation. I also want to take the time to please please check out the grantee spotlights during the comfort break, and also the closing remarks is scheduled for 4 to 5 o'clock. The next session, which is the innovative community response, and you can go under the session at the scheduled live time to go and join it.